It is my great joy and privilege on behalf of the Institute, of our team back home, on behalf of our university and the larger Partners in Health community to welcome you today to the launch of our and your institute, and also say a few remarks. First, we are honored by your presence and grateful that you took the time to be here today with us. Second, as we mentioned during our launch in Kigali, which happened last month, you are welcome by the Institute, by the university, and the PRH, as we believe this is a community where we would like to draw more, to grow bigger and faster. Thirdly, I keep believing that you are here for a reason today, and your presence is not by chance, but has a purpose. Same goals and dreams that we share with the larger global health and equity group. Welcome, and thank you for being here today with us. The launch of our institute comes at the right time, shortly after the commitment made at Clinton Global Initiative and after the United Nations General Assembly. The university and the PRH were on the stage, in the center of the attention, driven by our mission, by the principles and the strong ethics which make us really unique in the world. Now is the time for us, the ambitious and visionary Institute for Global Health Equity Research, to commit to the most powerful and innovative research to address the global health inequalities, finding solutions to alleviate suffering, while training the next generation of health leaders and world changers. We have a full agenda, as you have seen, with addresses from our founders, Andrew Weiss, our newly nominated Chancellor, Jim Kim, who I believe does not need any introduction, leadership of PRH, our Vice Chancellor, Professor Agnes, Rwandan government, a panel discussion on current hot topics on global health and equity, and the Nobel Prize winner on health economics. I encourage you to be present, to be bold, to take advantage of listening to us as we commit to a fairer world where everyone should have access to health, where we share with you our dreams and ambitions and the way forward. Distinguished participants, colleagues, and friends from the entire world, online viewers and listeners, a warm welcome to the official launch of our institute in Boston. So let's define shortly the Institute of Global Health Equity Research in a few words. Research, innovation, impact, equity. As our vision, we have embarked on a journey to become Africa's leading Institute of Global Health Equity Research, recognized worldwide for our innovative approach, impact, inclusivity, and togetherness. Our narrative connects our people to our institution. Our institute is defined by its members, young, vibrant, energetic researchers with great moral values and inquisitive minds whose scientific curiosity shall lead to ambitious discoveries in the service of health equity. Looking ahead begins with knowing who we are. It helps us understand who we can and will become. Values that define our brand personality: we are inclusive, determined, understanding, innovative, and more than anything, equity-based. The Institute of Global Health Equity Research is at the crossroads, advancing towards high-precision medicine research and training the next generation of top-class researchers. It is part of the University of Global Health Equity, part of PIH, and the vision of the university and of the institute is to train the next generation of global health leaders with emphasis on transforming them into change makers, equipped with the skills to protect the most vulnerable and also to improve health outcomes and social systems. The vision of the Research Institute has the community, the African community in the center, and responds to the most relevant research questions while looking for solutions for the future. Africa of tomorrow starts with our actions today, which we need to transform our imagination of a better world into reality, health to become accessible to all. The launch today is about people writing the narrative, defining our values, and keeping our culture. The launch today is a promise which we make towards you all, towards the global health equity community, towards us, towards our patients and communities, that there is no return on. We want Africa to know about us, we want the world to know about us, and that equity is the only acceptable goal, as Paul Farmer so elegantly has said. The Africa of tomorrow starts with our actions of today. And I would like to pause and ask you, the respected audience, if not us, then who? And if not now, then when? Imagine a world with equitable healthcare where equity is not just another word, but transforms into reality. And I would like to share with you the video with the team members, the people who are part of the Institute, who are behind the work, the efforts, and the ambitions and the dreams to take this Institute really to a level where it was never been before.
My reasons for joining the Institute of Global Health Equity, in fact, the interest dates back to 2019 when I first visited Rwanda. So I thought this is, the Institute actually offers the venue for more collaborations to bring in research funding and to help train the scientists from Rwanda and within to address issues of global health.
Before joining UGHE, I worked as a medical doctor in both rural and urban hospitals here in Rwanda. I noticed some undocumented challenges due to lack of equitable research in all health aspects. For instance, we used to rely on evidence generated by others in our daily practices because very few clinical trials take place on the continent, yet Africa represents the most diverse genome in the world, and this leaves many health issues unaddressed. That prompted me to join IGHR to contribute to health research for equity.
My goals in life are to conduct meaningful research projects and to improve health equity for my patients.
When I came to Rwanda for the first time, I was looking for a host institution to support my research permit application. Given the prestigious status of the University of Global Health Equity, it was the ideal institution. In fact, it turned out to be more than ideal. The IGHER has an international team full of talent and expertise in global health research, and a strong network in the health system of Rwanda.
I'm Abel, I'm a visiting fellow at IGHER. I was first made aware of the Institute's work through the University of Global Health Equity, and then through a fellowship that I received, I was able to come as a visiting fellow. Joining the team here was an easy choice for me, as it presented the opportunity to work with and learn from passionate leaders from across Africa on a project that actually mattered to me. While here, I'll be working to identify barriers in accessing cancer screening and diagnoses, and thinking about potential solutions.
UGHE focus on conducting research, and second component is training. So joining an institution that combines both research and training is an opportunity for me to leverage that.
I joined the Institute of Research because I was curious as to how research can contribute in eradicating health inequities in Rwanda, in Africa, and in the world.
For me, global health was born through global oncology, love and care, empathy, and sharing protocols so much needed on the continent. The commitment and passion and of partnerships and collaboration on the continent, which was so much and is so much supported and encouraged by many in all parts of the world. The Institute of Global Health Equity Research is also about bringing the best scientists in Africa and also unite them with the best scientists and researchers in the world. Why? To focus on some of the most critical problems in the world. And it is also to be able to produce the evidence so much needed for transformation and change.
The research I plan to do when visiting the UGHE is part of my doctoral project to study the impact of social health insurance on the incentives of healthcare providers in East Africa.
So what I really bring to the Institute is my experience. I have trained various students at undergraduate and master's level and have been successful in many competitive funding opportunities.
In terms of focus on research, I would like to see more researchers focusing on both infectious as well as non-communicable diseases, which has been in the rising over the last decade. And in terms of research gaps, I see three important research gaps. One is translation of research into policy and action. I think we lack that in Africa. UGHE is pioneering in terms of conducting implementation science research training in Rwandan setting researchers in Africa.
For a young female scientist in the field of research, which is predominantly filled with male scientists, let me tell you something. Science is not only for men. You can do better and you have everything it takes. I personally used to doubt myself in science because some people used to doubt me. But one day I told myself, if others can, why not me? So since then, I had to stand up and see where I am now and still growing day after day.
There are many challenges and inequities we're facing in the world today that I believe as an institute, we can challenge ourselves in creating solutions for today and tomorrow.
And I'm very confident that we will be able to do this. We will be able to shift the center of gravity for Africans by making sure that our trainings are tailored towards addressing the equity challenges that we face as Africans.
As one of my great influencers, Nelson Mandela, said, education is the best tool, weapon to transform the world. Our institute is advancing well on the mission of training and forming the next generation of researchers, scientists, women researchers and scientists, health leaders who will stand on our shoulders and see a broader horizon for all. So it gives me now great pleasure to introduce to you Andrew Weiss, the founder of the Institute. And how much do we know about him? Who is Andrew Weiss? I would start by describing him in 2 words: brilliant mind. And I have as testimony over 60 articles published in professional journals and ranking in the top 1% of published economists by citations in the entire world. And I would continue adding this statement from Boston Global. A brilliant economist, he's an outstanding investor. He's scrupulously honest, and I would trust him with anything. Weiss founded the Weiss Asset Management Foundation and co-founded together with his wife, Bonnie, CRI Foundation, both which are dedicated to fighting poverty in less developed countries. They also established the Weiss Family Fund, which supports research in development economics at leading universities. And when talking to Andrew, one of the first phrases that you'll hear, first and last, it will be about his efforts directed towards alleviating suffering. Something which is said repeatedly about him is honesty and integrity. At Weiss Asset Management, with nearly 100 employees, a firm which he has led since 1991, Andrew tells the new hires, never do anything that you wouldn't be proud to tell your kids and grandkids about. And again, I will end with one of his statements. We believe people matter the most. So, Andrew Weiss, a brilliant mind with honesty and integrity and a sense of humanity to help make this world a better world. And we are fortunate to have him as our founder and friend at our institute. Thank you, Andrew.
Thank you very much. People hear me without a mic. No. What? Okay. Oh, okay. I don't do so well standing still. Does this come off? Okay. Oh, okay, that would be great. Does this work? Is this working? Okay. All right. Like I said, I don't do so well standing still. It's really a pleasure to meet everybody here. It's really exciting. There's great thrill, wonderful turnout. And I'm really just thrilled to be here. 5 years ago, I was in Kigali, sitting on the porch at Dr. Benuahu's house, and we were sketching out the idea of an Institute for Global Health Equity Research. And now it's happened. This is really a remarkable achievement, especially given the obstacles that we faced with COVID. So I'm just delighted at what's happening. I'd like to talk about what my vision for this institute and what problems it's going to address in the long run. I think, I appreciate what Christina said, but I think she, in some ways, understated how important this can be, what we're doing. If we look at research in serious diseases, there's like a real problem. Let me explain the problem. You have the best researchers in the world are in places like the Brigham and Mass General Hospital. If they want to study, what are the diseases? A lot of the diseases are diseases like helminths, soil-based worms, leprosy, malaria, TB resistant, drug-resistant TB, diseases that have very few victims in the developed world. So if you want to study these, if researchers at MGH or Brigham want to study these diseases, good luck. If you wanted to try to have a vaccine against schistosomiasis, you really couldn't conduct a trial in the United States. There aren't enough people just don't get schistosomiasis in the United States. Even if you look at Africa, you're not getting Chagas in Africa. So these diseases are kind of around the world, and the researchers, the best researchers, and a lot of the money for research is in the US. So what do we do? So the problem is, if the researchers want to go to Africa to do the research, or to Latin America, you don't have the infrastructure, the framework. You don't have the genome banks, as was mentioned. There's more genetic diversity in Africa than in the whole rest of the world put together. You don't have the enumerators, the trained community healthcare workers that enable you to do the research. What are we going to do about this? Well, we're going to take a three-pronged approach that will lay the foundation for progress. If the three prongs are the Institute for Global Health Equity Research in Rwanda, which is going to be the spearhead, not just for Africa, but I believe for all the 12 and growing countries that PIH is working in. So we're going to be able to concentrate the resources there. We're going to have a genome bank, we're going to have a tissue bank, we're going to have a biome bank, we're going to have training programs to lay the foundation for researchers throughout the world to work on these incredible health problems. As Christina said, my mission is very clear: alleviation of suffering. I really don't care how it happens, who does it, frankly. I care about the victims. And we're going to take a long-term approach. The second leg of this is the collaboration with the Brigham and MGH, there are people here from those institutions, and we're working with them so that they can collaborate and so we're not reinventing the wheel, so they can be mentoring people. They can be mentoring researchers, they can be taking people how they've set up biome banks, how they can make use of the medical equipment that's available, because a lot of people like the Broad Institute seems to be overstocked with medical equipment, how we can bring that medical equipment to the Institute. The third leg of it is PIH, which is in 12 different countries and with many institutions in these different countries, ranging from Haiti through Rwanda and Malawi and other countries in Africa on to the countries in the former Soviet Union. There are different problems in each of these places. We're not going to be focused on specific problems. We will, in a sense, because one way to train people is by working on a problem. But the emphasis here is going to be on providing the foundation, the bones for all kinds of research that we might not even know we need to do now. It's going to be getting the fundamentals down. That's why we've made a 25-year commitment. Weiss Asset Management Foundation and some anonymous donors are committing together are pledging $25 million toward this long-term aim of getting a structure that will enable path-breaking breakthroughs on all sorts of diseases. One way to think about this is, would we be better off in the 19th century testing a whole bunch of herbs on a particular disease, or funding research on the germ theory of diseases? Well, the germ theory of diseases has probably affected healthcare in just enormous ways, sort of swamped the previous thousands of years. Research on the circulatory system. But that research takes time, and it takes commitment, and it takes collaboration, and it takes bringing to bear some of the best minds in the world, some of whom you're going to hear from today. one of whom I'm going to introduce today. So I think, I view myself, I think Christina almost understated what we're here at. If this works, this is going to be game-changing. This is going to be just an incredible effect, an incredible force multiplier for all the researchers. And, I think this is just incredibly exciting, incredibly impactful. And I think you people, you should mark this date on your calendars, because this could be a key date in the history of addressing global health problems, instead of addressing them piecemeal, by laying the foundation for a worldwide coalition to come together to get the basic research done that's going to address all of these unaddressed health needs throughout the world. And I feel privileged, honored and privileged to be part of this initiative. And I hope you share my enthusiasm. Thank you.
So for sure, this is going to be a memorable day for the Institute, and not only for the Institute. Already the Institute of Global Health Equity Research is unique in the world, and definitely we will try to reach the high standards and the ambitions really to move the global health agenda and the equity to really another level that was never achieved up till now. So we did hear your message, Andrew, and count on us. We are really going to make the impossible possible. So this is the date that everyone is going to remember, 27th of October, 2022, launch of the Institute. So please allow me to continue introducing the next speaker, who is Dr. Joe Rhatigan, who is the interim chief of the Division of Global Health Equity at Brigham and Women's Hospital, director also of the Brigham Hyatt Global Health Equity Residency Program, and director of the Global Health Delivery Partnership. Joe, if I may say, as we became friends for the past few weeks and months, since he was really supporting us and the Institute. He's also a professor at our university, graduated from Harvard Medical School and completed his residency in internal medicine at Brigham and Women's Hospital, where he's practicing hospital medicine. His work examines the delivery of health services in impoverished settings through case studies. He also works to strengthen health professional education in Rwanda and co-directs the Harvard Summer Intensive Program in Global Health Delivery. He is currently an associate professor at Harvard Medical School and also at Harvard School of Public Health. So Joe is going to address the audience representing the leadership of PIH.
Thank you, Christina. So as Christina mentioned, I have a few different hats I wear in my professional life. I'm going to speak to you today as the chair of the Global Health Delivery Partnership. What that represents, so the Global Health Delivery Partnership is a term that we use for the shared work of partners in health that Sheila Davis leads, the Harvard Medical School's Department of Global Health and Social Medicine that Alan Brandt leads, and both of those folks asked me to send their regrets. They couldn't be with us today. And the Brigham and Women's Hospital Division of Global Health Equity, which I'm currently the interim chair of. Our three organizations have been working together for 2 decades. And we were originally brought together under the leadership of Jim Kim, who you'll here in a few minutes, Ophelia Dahl and Paul Farmer. What I hope to do in the next 5 minutes is to briefly share with you some of the history of our collective involvement in Rwanda, so that you can better appreciate what an exciting and significant opportunity, just as Andrew described, the launch of the Institute for Global Health Equity Research represents. So in 2005, PIH first began working in 2 districts in Rwanda, Kayonza, where Rwinkwavu Hospital is, and Kirehe, at the invitation of the government, and helped start its sister organization, Itsuchi Mutsubima, or IMB as we commonly call it, which means Partners in Health in Kenyan Rwandan, shortly thereafter. Joya Mukherjee, who you will also hear later in the program, was one of the first PIH doctors to work there. And at that time, Rwinkwavu Hospital was dilapidated, semi-abandoned. It really had no reliable staffing, and it still showed signs, including bullet holes in the walls, of the violence from the recent genocide. The entire district of Kirehe didn't even have a hospital. This is for a population of about 250,000 people. The burdens of HIV and TB were high, as was maternal mortality and infant and child mortality. In designing their HIV treatment program, PIH imported the use of accompagnateurs that they had pioneered in Caraballo, Peru, and in Haiti. Accompagnateurs are similar to personalized community health workers, if you don't know what the term means. These are members of the community who provide directly observed therapy for HIV and tuberculosis, social and psychological support for folks suffering from illness, and a link to the district hospital. PIH and IMB strategically designed the HIV program so that not only would it have some of the best outcomes in the world, but it would also strengthen the primary, the first line healthcare for patients afflicted by any illness. Slowly by slowly, over the ensuing years, PIH, IMB, and the Ministry of Health, and the communities of Rwinkwavu and Kirehe, and later Butaro, built the healthcare systems that today serve hundreds of thousands in these districts. In 2012, with the help of the Dana-Farber Cancer Institute, the Butaro Cancer Center was opened to address the previously hidden burden of oncologic disease in Rwanda. That same year, in 2012, the Brigham and Women's and Harvard helped lead the Human Resources for Health program. This was a 7-year, multi-million-dollar grant from the US government to the Rwandan Ministry of Health that was secured by Dr. Agnes Binagwahu's outstanding leadership. The Rwanda HRH program worked to increase the number of health professionals in Rwanda, including specialist physicians, nurses, hospital administrators, and dentists. Dr. Robert Riviello, I think, is here, as well as Lydia Pace and Jean Buchmann, all who worked extensively on this program. During this time, there was also a nationwide expansion of services for neglected health conditions, led by IMB and PIH and the partnership faculty, not only in cancer, but in essential surgery, in other non-communicable diseases, and in mental health. And in 2015, with the visionary generosity of Bill and Joyce Cummings, thank you, the University of Global Health Equity was launched. In relating this story, I want to emphasize that this is not a story simply of charity. Although enlightened philanthropy played a significant role in this story, and thank you, Joyce and Andrew and Bill and Bonnie, at its core, it's a story about the public-private partnership between IMB and the Ministry of Health. It's because the government of Rwanda has invested in health both as an essential human right and as a path to economic development that these achievements have been possible. And this is also not only a story of irrigating the clinical desert, as Paul would often say, but rather one that involves service, research, human resource capacity building, and advocacy. Research and documentation in the scholarly literature have been an integral part of the partnership's work in Rwanda since the early days of our collaboration. In 2008, the Doris Duke Charitable Foundation awarded a multi-million-dollar grant to the Brigham, IMB, PIH, and HMS to study the population effects of a package of healthcare interventions. These were messy and complicated interventions to study. They included such things as efforts to strengthen and increase the number of community health workers, as well as to provide mentoring and supervision to frontline nurses. Many more research grants followed. Over the years, more than 30 Brigham faculty and their HMS colleagues have authored over 100 journal articles. This work has helped inform health policy in Rwanda and across Africa. And this has not been parachute research, but rather research done with a deep commitment to improving healthcare delivery and driven by the priorities of the Rwandan health system. In addition to collaborating on research, the GHD partnership has also sought to build up local research capacity. Bethany Het-Gauthier, Molly Frankie, Cheryl Amoroso, and Megan Murray have all worked diligently to provide not only research training programs in Rwanda, but also one-on-one mentorship with their Rwandese colleagues, several of which have published first author journal article, peer-reviewed journal articles. This virtuous cycle that has always been PIH's and the partnership's secret sauce, which is to meet the immediate health needs of the community, to document and evaluate the interventions, to train local staff, health professionals and researchers, and to use research to inform policy and spur innovation, has always been at the heart of the partnership's mission. We've done this first with HIV, then MDR-TB, then with cancer, then with other non-communicable diseases, then mental health, and we still have dozens of more health conditions to tackle. So today's launch represents both a culmination of almost 2 decades worth of work and the beginning of a new chapter in this story. The Institute for Global Health Equity Research will not only strengthen the ongoing research and the collaboration between the government of Rwanda, PIH, the Department of Global Health and Social Medicine, and the Division of Global Health Equity, but it will also provide opportunities for new avenues of research. It will facilitate the engagement of other researchers who are drawn to improving health equity, both from across the PIH network of countries, but also across the globe. It will allow UGHE to develop into a university that trains outstanding leaders and physicians and does outstanding equity-driven research. Thank you, Bonnie and Andrew, for believing in the power of partnership and for this generous visionary gift.
Thank you, Joe. It gives me now great pleasure to introduce to you Jim Kim. And I was really thinking, how should I introduce him? Does he really need any introduction? And I mean, from my point of view, I would start by just saying he's our chancellor. And I don't think of anyone better than him to be our chancellor. And I'm so proud that I can work in a university where Jim Kim is our chancellor. But let me read some of his biography, which I think it does not make any justice to whom really Jim Kim is. He is the vice chairman and partner at Global Infrastructure Partners, a fund that invests in infrastructure projects across several sectors around the world. We know Jim as the president of the World Bank. He served between 2012 to 2019, and he was the 12th president of the World Bank Group. And also we know that soon after he assumed that position, the organization established 2 goals to guide its work: to end extreme poverty by 2030 and to boost shared prosperity, focusing on the bottom 40% of the population in developing countries. And I don't think that it was never, ever other president of the World Bank with such an ambitious target. During Kim's tenure, the World Bank Group supported the development priorities of countries at levels never seen outside of a financial crisis. And along with partners, the World Bank achieved 2 successive record replenishments of the institution fund for the poorest countries. The World Bank Group also launched several innovative financial instruments, including facilities to address infrastructure needs, prevent pandemics, and help the millions of people forcibly displaced from their homes by climate shocks, conflict, and violence. A physician and anthropologist, Kim's career has revolved around health, education, and improving the lives of the poor. Before joining the World Bank Group, he served as the president of Dartmouth College and held professorships at Harvard Medical School and Harvard School of Public Health. From 2003 to 2005, Kim served as director of the World Health Organization's HIV/AIDS department. He led WHO's 3x5 initiative, the first ever global goal for AIDS treatment, which greatly expanded access to antiretroviral medication in developing countries. In 1987, Kim co-founded Partners in Health, a nonprofit medical organization that now works in poor communities on 4 continents. Kim also received a MacArthur Genius Fellowship, was recognized as one of America's 25 best leaders by US News and World Report, and was named one of Times Magazine's 100 most influential people in the world. So he's going to join us through Zoom.
Of Andrew Weiss. I mean, this is exactly the way we should be thinking. A lot of people don't know this, but the very beginning years of Partners in Health were wrapped around trying to do the kind of research that would stop others from saying that things are not possible. So for example, among the early decisions we made were that people like Mercedes Becerra and Carol Mitnick should really focus on MDR-TB research, because the excuse for not treating people with MDR-TB was based on what Paul Farmer used to call immodest claims of causality. There were all kinds of sort of accepted wisdoms in the field around multi-drug resistant TB that were just not based on data. And so Mercedes, Carol, Megan Murray did absolutely critical, very sophisticated epidemiological research that was critical in literally lifting a death sentence that the World Health Organization had put on anyone living in a poor country suffering from MDR-TB. So the fact of doing better research with better methods, with better, coming from better intellectual foundations, this was actually critical in assuring the right of poor people in poor countries to care for MDR-TB. We saw the same thing in Africa. It was a little bit different in the sense that everyone knew that the HIV medications were very useful, but once again, immodest claims of causality. You cannot do HIV treatment in Africa. We literally heard this from everybody. One of the very, very few people who were not going around saying this is impossible was Tony Fauci, luckily for us. And Tony would say to us, I've never done that before, and I don't know, I can't tell you for sure that it is or is not possible because I don't know. But if you guys tell me it's possible, then I have to stand with you because it's the right thing to do. And so over time, the efforts to show that not only was it possible, but it was critical, and that providing treatment was probably the best way to prevent the spread of HIV. All that data came out. So the research was important around that question as well. The other thing that I think happened at Partners in Health that's so important, and that I hope that the UGHE research group can support, is the movement from looking at specific questions. Is MDR-TB as transmissible as garden variety TB? That was a very specific question we had to ask. But now I think the questions that are so important are, so when you know that something is the right intervention, when you know that drugs are the right drugs, how do you take those to scale? This research is harder, it's messier, but I think that the UGHE research group could make progress on looking at those questions with great rigor, with the best methods, in a way that I just can't imagine any other institution being able to do. Linked to Harvard, linked to Brigham and Women's Hospital, we can do that kind of delivery research, as we've called it, in a way that I think will absolutely be world changing. So my hopes as Chancellor for this effort at really doing world changing research is, first, that the intellectual methodological foundations will be rigorous, state of the art, and of course, I have little doubt that we will be able to meet those standards. The second is that we have to ask questions that are of relevance to Africans. We heard that in the video very clearly, and it's only through deep engagement with our African partners, with the researchers who are coming from all over the continent, that we can really understand what the most relevant questions are. The third is to move from doing wonderfully focused research on specific questions to looking at the broader implications for delivery and scale. Those are the issues that are neglected so often. So many researchers say, well, I've got this intervention and we know it works, just do it. Well, the just do it part is so important, but it's also very complicated and requires the kind of research that I think this institution can do. And finally, something that's been so critical is that a commitment to social justice, a commitment to the communities we serve, discernment about the questions that we should be asking, and also a commitment not to stop where others have stopped. Paul always talked about conversation starters and conversation stoppers. People would say things to us like, well, you can't do HIV treatment in Africa, it's just not cost effective. Or you can't do MDR-TB treatment in Peru because it's too complicated. Those kinds of broad statements for so long and for such a large portion of the global health world have been conversation stoppers. I hope that through discernment, through commitment, those questions will be conversation starters for us that will not stop where others stop and continue until we can achieve this truly bold vision that Mr. Andrew Weiss has given us, and for the enormous generosity of the gift that I think will make that possible. Thank you very much, and I look forward to seeing you all in person very, very soon.
Talk, I'm just going to introduce Esther. Esther's one of the great people of our time, just to, in a couple of words. I mean, she's not only one of the great economists, she's one of the great researchers, but more than that, she's one of the great human beings. Before I sort of give our resume, talk about her, I'm going to give you a preview. I'm going to say something. The reason I agreed to give the presentation is she's actually changed my life. And that'll be I'll get to that in a few minutes. So Esther, you know, had like a path-breaking career. She got tenure within 3 years of her PhD. She got a PhD, you know, within a year of getting tenure at MIT, she became a full professor at 30, which is pretty remarkable. More than that, she basically laid the pathway for what we're trying to do at the Institute. She didn't just sit back and write more and more articles, although her articles have been very influential there. Some of the articles that are most assigned in college curricula, and which is even more special because they're applied work. A lot of the articles that get assigned in college curricula are more theoretical and, you know, or statistical. But she did something different. She founded JPAL, where at that point it was the Poverty Action Laboratory at MIT. That is, in some ways, the model for what I see at the Institute. The Poverty Action Laboratory gives the structure for people to do path-breaking research from any part of the world. And nobody had done this before. I mean, this is Esther she's still young by my standards at least, but this is a very young version of Esther, not sitting back and creating a structure that would advance research everywhere. The next step was her student. Dean Carlin founded the Innovation for Poverty Action in New Haven to sort of implement that research. Siga followed at UC Berkeley, followed in her path to also support research mostly through the UC system. And most recently, she founded the Fund for Development Innovations in France, which is duplicating or advancing that through the French development program to, again, do path-breaking research and laying the foundations. It's not like she's starting a particular project for a particular problem. She's set up the framework for addressing a wide variety of problems. Now let me talk about why I agreed to give this talk, because anybody could have said these things about Esther. So when Esther won the Nobel Prize in 2019, she did something that literally changed my life. She and the co-Nobel Prize winners donated their prize money to the Weiss Fund for Research. I'm not very weepy, but even talking about it, I'm getting tears in my eyes, I'm choking up. In some ways, this validated my entire life. Having them do that gave me a feeling that, yeah, my life was really worth something. It's not like people telling me, oh, you're wonderful, wonderful, wonderful. This is real. You know, a lot of money by people who I deeply respect. And, you know, I can't tell you how much I thank you, Esther, for having done that. Thank you. This is Esther Duflo. One of the great, by the way, again, one of the great people of the first half of the 20th century. Not just one of the great economists, one of the great human beings.
All right, it's downhill from here, I'm afraid. Thank you so much. Thank you for having me. Thank you for what you're doing, for what you're about to do. Thank you, Andy and Bonnie, for making it possible and for making possible, and again, great research in developing countries. I realize I have no control on my slides. So I'm gonna, let me first maybe rebound on what Andy said and also explain why I'm here today, why I was very pleased to come here today. Actually, first a small correction. I didn't found JPAL, I co-founded JPAL with Abhijit Banerjee and Senthil Mullainathan, and then Rachel Glenster was our first executive director, and she made it what it is. And the reason why I'm correcting that is because Everything we have done has always been as part of a movement. There's nothing I've done that was done alone. I'm pretty convinced that if you blew away every single of my research paper, not very much significant would really disappear. But because so much more was done in the process, in the movement that has brought research in development economics and in other fields to improve the lives of the poor. So when the night where I was called, we were told that we had won the Nobel Prize, I was also told, oh, since you're a woman, you have to do the press conference. It was 4. I said, you go have to take a shower, get yourself a cup of tea, and prepare yourself for the press conference. And so I did. And so I was not particularly cogent by the time this 6 o'clock happened, but they asked me, what are you going to do with the money? And it's not that I've been thinking, like, all this time I'm going to win the Nobel Prize. I better have my answer ready. And what I said, purely reflexively, I remember the book that I read about Marie Curie. And when she won the Nobel Prize, what she did with the money is she bought a gram of radium because she wanted to use that money to further what her life was about. So what I told them is that, well, I don't know what I'm going to do, but it's going to be a gram of radium, or the equivalent of that. And then after that, it really didn't take very long to figure out what could be a gram of radium. And it was really to further the only way in which we could make this money being helpful, or the most helpful, was to further the research of younger people, students, people in other universities around the world, to continue launching projects, succeeding, failing, accumulating. And there was no really other place to do that than with the Weiss Fund that was all devoted to do this. And it was a way of not only furthering it, recognizing it, and I think it's been a very good, very, very good use of. I've never had so much money in my life, and never will I have so much money in my life, and it was a very good use of that money. Which brings me to your enterprise, which I see as very, very similar, very at least a kindred spirit of finding ways not only to conduct the research, but to enable many people to conduct the research that may or may not have had this opportunity. I actually do think who conducts the research does matter. At least it matters a lot in economics, because without the diversity of viewpoints, then without understanding what the problems are about, then the research can easily become siloed into whatever it is that is like the fashion of the moment. So actually, I don't think it matters who carries any particular research project, but I think it matters that the body of people who conduct research is diverse, is equitable, represents the world in which we operate. And for a lot of people in the world, it's just not possible to plug yourself into a successful research strategy because the money is not there, the time is not there, the infrastructure is not there. At JPAL, we are trying to do that. That's kind of was the idea, really, of creating JPAL as opposed to further our own project, is to create the backbone towards on which a whole movement could grow, made of academics, made of partners, made of policymakers, and so on. Both to make sure that we have access to the problems that are policy relevant and important, and that we have access to the diversity of talent to carry out the project, and that we in turn can share findings across the world. And I see this enterprise as doing the same thing in another field, or doing related things in another thing, and I think it's just wonderful. So these are for preliminary. Thank you very much for making this possible. Thank you for leading this enterprise. and I am very happy to be here. Now, on the substance, the question is what I can bring, not being a doctor, onto this, and I thought I'll talk a bit about some of the research, not just my research, but some of the research that has accumulated about how people on the ground, think about their health decision. Maybe we can go to the next slide. So the subtitle is why do people want steroids and antibiotics as opposed to vaccinations? That's a bit of exaggeration, but I'm sure if you've been in the field, you see a lot of that. That's certainly something we've encountered in India. So something which I encountered very, very early in my research career working on health is, so we did a survey in Udaipur district in India, just a descriptive survey about how people think about health of 1,000 households in 100 villages, asking a bunch of questions about how people think about their health. And this is a very poor area, tribal area, very, very disadvantaged people. And the first thing we found out is that people spend a lot of money on health. They spend about 8% of their budget on health, various kind of things, traditional medicine, allopathic medicines, qualified people, not qualified people, and so on. And often they have to spend 5,000 rupees for an expenditure and for a shock. And when they spend about several hundred rupees a month usually, and they will find the money. However, the second thing we find is that there is a low take-up and a surprisingly large price elasticity for preventive health technologies that we know, you guys know, I suppose, to be highly effective. So that's BedNet to prevent malaria, immunization, deworming drugs, and so on. If you click on that blue thing that says figure, we can, I'll show you a figure from, or maybe I will. Ooh. Yes. Which illustrates this point. This is from work by, a review work by Ted Miguel and Pascaline Dupas. What we have here is a bunch of preventive health technologies, very different ones. Some are super cheap, like vitamins of deworming. Some are more valuable, like water filters or bed nets. But they are provided to households at subsidized prices. And what you can see is that when they are given for free, many people are willing to take them up. But the moment you start charging for them, the demand quickly falls off. So for example, for bed nets, even when you arrive at about 60% price subsidies, only less than 20% of households will acquire one. For deworming pills, when you go from free to a few cents, you go to a take-up that is around 15% and so on. And that seems to be true across technologies, no matter a little bit what the cost of the underlying technology. If you go back, if you go down the thing, you will have a little things to come back to where I was. Yeah. No. I didn't plan that I wouldn't have. No, that's not it. Just go back to the beginning. You can then. You have to click maybe more than once. No, it's this, but because you moved, you already navigated, now it won't. Why don't you take this one and move it? Yeah, perfect. Then next one. I don't know why you can't be full slide. By the way, this is, of course, not just in the developing world. We've seen that play out at home with the COVID-19 vaccine. When go back down one slide. Now, these are for positive prices, but you find the same for negative prices. For example, incentives. So when you start giving people small incentives, you get large responses. One example is immunization. So still today, or at least pre-pandemic, now it's probably more, but it's because there was a lot of supply disruption. 25 million children every year didn't get immunized. Many of them in India and Nigeria, which are not particularly poor countries, so it's not related to poverty, to condition of extreme deprivation in the country, because many African countries that are substantially richer than either Nigeria in Africa or India have actually more immunization. So it's other things. And it doesn't appear, and it doesn't appear to do to a deep resistance to immunization, because when you ask people, contrary to the COVID-19 cases in this country, because when you ask people, we have I'll show you some data from projects we conducted in Haryana in India, and we actually ask people what they think of immunization. And 96% of the parents think immunization is wonderful and have every intention to immunize their kids. They just haven't gotten around to do it as yet. So the question is whether small incentives can make a difference. If you go down by one. So when we had finished this big survey of households in Udaipur, one of the things we found is extraordinarily low immunization rate, where less than 5% of children received all of the immunization they should have gotten by year one, so the extended package of immunization. That seemed to be a waste. We had a conversation with a stakeholder, with the government, with NGOs about what to do about it. And their view was mostly, we should really invest in supply, in improving the supply, which was a good idea because the supply, the nurses are not always here. Udaipur is it's not dense at all, so people have to walk a long time, and then they show up and no one's here, so they come back and get discouraged. So a lot of the effort is to improve the supply. And that is generally what has been done in lots of developing countries since then. But what we try to do is to say, look, in addition, let's try to give people a very small incentive to get immunized. Not something that is going to fundamentally change their views, because you cannot really change the people's view on such things, but something that is going to make the occasion memorable. So it was a kilo of lentils. And what we found is large impact on full immunization, especially on getting more than one shot. So almost everyone gets the BCG, the first one. But then the take-up, it's the DPT-1 is lower, and DPT-2 is even lower, and then DPT-3 is even lower, and then measles is the lowest. And what this helped do is to bring up measles and DPT-3 much higher. If you go down, so this is what we had in our data sets. So we run this as a randomized control trial. In the control group, 6% of kids were immunized at the end line. In the group where we just set up the camp, we had perfect immunization infrastructure for the duration of the experiment. We had 17% full immunization. And when the lentils were added, we had 38% immunization. And relative to this, it's not possible point, which I'm very sympathetic to. One answer we're getting often is that, we don't have the money to give incentives. It has to be sustainable. It has to be financially sustainable. So what's quite important here is that it's actually much cheaper. If the goal is to immunize kids, in this setting, it is cheaper to give incentives than not to give incentives, because even if you count the lentils as a cost, which arguably you shouldn't, because it's lentils that people eat, so it's a good thing. But even if you wanted to count this as a cost, still, because you have to pay for the nurse anyways, the more people show up at the camp, the more he or she works. And the big cost of running a camp is the salary of the nurse. And if you have immunized more kids, you save a lot of money. So it turns out that adding the incentive is cheaper per fully immunized kids than not adding the incentive. And that's actually important because it's something that people do not necessarily think about in advance or understand ex post, but is often true. Not necessarily, but is often true. It would be true in a setting like this one where in the absence of the incentive, almost no one comes. I can continue. This shows you again from this program where we get the effect, and you can see that it's not like at the BCG, at least one, it's as you move forward, the drop-off is lowest. We can continue. One of the reasons why you save a lot of money is that there is kids not only from this village who come up, but from neighboring villages as well. So you get like a lot of people coming around. So the question then, beyond the fact that maybe incentives for immunization is something we should think about in settings in particular where you cannot make it compulsory because you just don't have the infrastructure to deliver it. So you have to do something else to encourage people, is why this is the case. Like why we have this low demand for preventive health and high elasticity, high sensitivity to prices. It's puzzling in the way that, if you take the lens of the traditional models we have of how people should think about their health. Because these are things that have high benefits at some point. Getting immunized against measles can make all the difference to survival and to survival in good condition for a child. People definitely care about their health, so it's not that they don't care. They're willing to spend tons of money on it, so they care about their health and the health of their children. And the prices are not very high to start with. So why is it low and why is it so sensitive? So one of the reasons it could be low is if balancing this benefits, there are some costs we don't see, like people would not think that there are these huge potential dangers. Maybe that explained people's reluctance to get vaccinated for COVID, that they had made a whole theory behind why it could be dangerous. But in that case, then we wouldn't expect people to be sensitive to a few cents or a kilo of lentils. So it can't really be that something scares them that much, because otherwise I wouldn't be able to convince them with a kilo of lentils. So it can't really be that. So what else could it be? We can go down. One possible reason is this idea that of time inconsistent preferences. So what's time inconsistent preferences? It's best illustrated by the following example. If you sit down in the evening to pick a movie for that evening, you might, let's do it the other way. Suppose you sit down an evening to pick a movie for next week. You might decide to pick some French slow Robert Bresson movie that is going to be very educative and interesting. But then when that moment comes, you're like, oh, why don't we switch to a series about spies or something like that. So in other words, our preferences are not consistent over time. In the future, we think that we have highbrow tests, and in the present, we really would like something immediate, something more immediately rewarding. Likewise, some costs that we have to experience right now seems to be really important and essential. But if we think about it in the future, we think it's going to be much better. So think about a parent who is thinking about immunizing their kids. They need to take at least half a day off to show up to the facility. The kid's going to be cranky, maybe a little sick. So all of those are costs. They're not enormous, but they are real. And these are parents who have very, very busy lives. They have many other things that they are trying to juggle, many other concerns that occupy their life, and they could think, okay, fine, now I really can't deal with that. I'm too busy. I have too many things I need to deal with. But I'll come back next month when they come back again next month. And there is never really an urgency to immunize a child, as opposed to the urgency there is in dealing with the disease if the child is not well. So people will react to the urgency, but with immunization, they might think, I'll do it, for sure I'll do it, but I'll do it next month. And then, of course, when next month rolls around, then the same type of things are coming in a way, and you postpone and you don't do it. So in this setting, you might expect a small incentive to help because you have a small benefit that balances the small cost. So people need lentils anyways, and that's kind of a way of, at least there is a lentil, so let me go. Otherwise, I'm missing them for today. In most rich countries, there is a compulsory schedule of immunization that you can get out of. So it's not that it's compulsory, but it's sort of a default. And that kind of plays the same role, because if you don't get your kids immunized by the time they have to go to school, that's going to be all sorts of things that you have to deal with. That's painful. And that painful balance, the painful of actually getting the kids immunized, as long as people don't have strong ideology that stands in the way. So that could be a reason. In this world, subsidies play a role not just to correct an externalities, which is when I get immunized, it's good for other kids, but also to correct what economists call internalities, which is my decisions are not always optimal from my own point of view if I took the longer perspective. So to note, if time inconsistency is the main problem, then there are other things you could do. You don't have to do incentives. There are other things you could do to help, and then you can go down. This is kind of the world of like nudging from Richard Taylor and Kastenstein. It's basically steering people softly towards the individual that they would probably, the choice they would make for themselves if they could make it in advance. So the good default choices, or helping them to make a commitment to behave in a certain way in the future. So for example, it would be helping you choosing the Robert Bresson movie and not being able to get out of it. Then you would see more Robert Bresson movie, which would certainly be good for your soul. And continue going now. So this idea that we could help people to commit to behave in a certain way in the future is something that has interested economists a lot. And one very interesting study is from my colleague Franz Schilbach, who studied rickshaw drivers in Chennai. And at the baseline, the first thing he notices is a huge drinking problem. Like many of them drink up to 6 drinks in a night on a routine basis, and they recognize it to be a problem in their life. So what he does first is he invite them into a lab and for a few weeks give them small incentive to not drink. By basically every time they come to the lab sober, they are paid a bit more than if they come to the lab drunk by a test of. After they've done that for a while, he offers them the choice between between either a sure payment, come to the lab and you go every day, we are going to test you and pay you regardless of what we find in your blood, or an incentive. And there are different type of situation. One where the incentive payment pays you the same if you're sober and more if you're the same if you're drunk and more if you're sober. One where the incentive payment pays you more if you're sober, but less if you're drunk. And the third one is that the incentive payment is always lower than the sure payment. So if you were fully rational and not interested in getting an incentive, in forcing you to stop drinking, you should always pick the sure payment in the third choice because you cannot do better than sure anyways. And then the other two is somewhat ambiguous depending on how much you think you can, you think you can stop drinking. And what is really striking is that 1/3 of people chose the incentive when they are sure to lose money. 1/3. That means that there is a real demand for commitment, which shows that people in Chennai, the rickshaw driver understand that they have an issue and want to do something to deal with it. So we can continue. So this suggests that this idea of time inconsistent preference is at play. But in my opinion, it can't be the entire explanation for why people don't get their kids immunized for the following reason. What this also shows is that people understand they have a problem. And we see that in many circumstances where people, especially poor people, are often much, much more sophisticated than richer people because the possibility of an error looms large, and you can't really get things wrong without large consequences. So you see, for example, when you make people think about financial problems, the poor people actually being much more sophisticated than people who have more money because the people who have more money can afford the error. They don't spend. So people have this issue. I think it's profoundly human to have time inconsistent preferences, but they also know it and they keep doing things in their life to deal with it. then it would seem that they would have figured out by now that 6 months later they still haven't immunized the kids for measles. So they can't just keep postponing. And one day they're going to say, I'm just going to do it now. It's not the good time. But I have now learned for the past 6 months that it's never the good time, and I should do it. So in my opinion, that can't be the only reason why people are so sensitive to prices or so sensitive to incentive. There has to be something else. So one possibility is that that's about our understanding of health, and that even though the benefits are large, the perceived benefits might be lower. I think so I'm going to talk through these things instead of showing you my nice graph, because I'm a little concerned about the losing time. So one indication of that is that when you are able to provide very relevant information in information campaign, you get a large impact. So for example, Pascaline Dupas has a study where she, in Kenya, where she told kids, she first surveyed kids and realized that both boys and girls, teenagers, tend to think that the most risky partners are other teenagers, and the safer partners are older men, because the older men, they are called the sugar daddies, they are serious people who are faithful to their wives and themselves. Forgetting the fact that, well, their wives and themselves is like already one person too many, and in addition, just because HIV is stock, they had many more times to be exposed in their life. So in reality, older men are much, much, much more risky than younger boys as sexual partners. So what she did is just to inform them of that fact. And this is, and she found very large impact on a teenage pregnancy with older men as fathers, which is kind of a sign that there was less unprotected sexual relationship involved. Even better is when you can give people an experience. So, but still, Pascaline Dupas provided bed nets for free, and then several months later came back and asked both people who had received the free bed net and people who had not whether they want to purchase a bed net. So for the one who have purchased a free bed net, that's their second one. And for the one that haven't gotten one, that would be their first one. So you would imagine the people, and she offers them at the same price. So you would imagine the people who don't have a bed net need one more because they don't have one yet. But in fact, she finds the opposite, which is people who got the first one for free are more willing to pay to buy themselves a second one, likely because they got used to how they work, and they realize it's not that bad to sleep under a bed net, it's not that hard, it's not that complicated to install, and it really keeps the mosquitoes away and the malaria away. So there is learning in the experience as well. So all that to say that there is clearly big things that people don't know and about health and about the impact of these technologies. And one difficulty with health is that learning about health is extraordinarily difficult. First of all, because most diseases are self-limited, so they go away on their own. So if you think that taking an action, so taking an expensive drug or taking some particular treatment is going to work, you take it, and then you get better. Then you think that what you just did was the reason for why it got better. So that's like the causality fallacy that we keep being subject to that in our life. That's why French people love taking antibiotics so much, because they are used to taking antibiotics all the time, and they get better because you do get better regardless. And with preventive care, it's even harder because it's very, very hard to link a behavior with a future disease that doesn't happen. It's maybe easiest with COVID, where there's so much at the same time, but take measles. It's not that everybody gets measles like every 5 minutes. So you immunize the kid today, and then in the intervening period, they are less likely to get measles. How are you going to observe it? It's in your day-to-day lived experience, the two are not well linked. It's even worse when it's a behavior that has externalities, because you by getting the treatment, the preventive treatment, you're also helping around the other ones. So for example, in deworming, because the worms are so contagious, if some kids in a classroom gets dewormed and the other don't, nobody gets worm, or everybody gets fewer worms. Then the parents who deworm their kids were like, this was useless. It's not that my kids have less worms than the other one, it's all the same. And so this is, in fact, Michael Kremer and Ted Miguel have a paper showing that people learn the wrong message from observing the data, just because the data is pretty hard to deal with. You can continue. In this circumstance where we just cannot learn from our own lived experience, we need to trust what we are told. That's true for me when I go to my doctor. That's true for people in India or in Rwanda or in Kenya. And the problem is that we have really, we as a sort of a general we representing the elite in a sense, have not earned that trust. Have in fact done everything to not be worthy of that trust. In India, for example, during the emergency period, people were sterilized under the guise of receiving medical care. To these days, today, people are concerned when there is an immunization campaign that it might be a way to sterilize them. And in some places, it's very deep, particularly in Muslim communities that think that it's just some way. And it's not crazy because it happened. Another example that you may remember is when the CIA was looking for bin Laden, they needed to be sure that he was present, and one way to do that in the compound that they wanted to attack, and one way to do that was to ensure that the kids present had his DNA. And they sent around immunization people to conduct immunization campaign, collecting DNA swabs, and in this way, they could ascertain that kids with a genetic material related to bin Laden were living in the compound. It was effective from the point of view of finding it. Whether it was useful or not, I think is dubious. Is a bit dubious. But what is clear is that, and there is a very nice paper on that, showing that where it happened, people have become completely anti-immunization because they think immunization is potentially another way to do something else than what it's announced. Another example from history is from the French government, French colonization of Afrique occidentale française. At some point, they got concerned about sleeping sickness, and they undertook massive and misguided immunization campaign, which got a lot of kids sick. And then when you compare Cameroon, which is partly all British, partly all French, just at the border, the places that were subjected to this campaign today are much less trustful of medicine, are less likely to immunize their kids, and so on and so forth. So history has a very, very, very long shadow in health, partly because we do need to rely on the trust, and we haven't harmed it. So that could be another reason why maybe it's not so puzzling, because the perceived benefit might be much lower than what the actual benefits are. Let's go down. I'll give you another example of this impact of trust, again coming from Pascalin's work. So it turns out that there is a new, very powerful medicine against malaria, ACT, artemisinin combination therapy. And people can get it in the pharmacy. And because it's curative, people are very willing to do it. So at the first symptom of malaria, they show up, and if it's subsidized, they show up even more. But the problem is that many people who think they have malaria don't have malaria. So therefore, the medicine is overused, and that contributes, I don't know if that's true with ACT, but certainly with antibiotic as a huge contribute to the development of resistance. And certainly has contributed, all the therapy, you tell me whether ICT can develop resistance, but I assume it does over time. So that's a problem. So the solution is to test people before they're giving them the medicine. And in fact, there is a rapid diagnosis test that exists that people can take. So what they did in this work is they subsidized the test. So when people show up at the pharmacy, instead of immediately getting the drug, they offer them to take a test first. And if the test is subsidized, everybody is absolutely willing to do it. Go down. But the problem is the compliance rate to the test results are not very high. So this is the compliance on the B chart, the tall ones, are the compliance rate when people are in fact positive. So if the test tells them they're positive, they all buy the medicine, pretty much regardless of the price. The subsidy levels are below between 80% and 92%. But if the test says they don't have malaria, many people take it anyway. The compliance is low. That is, people just tested negative and they take the drug anyway. And why does it happen? It's because they don't trust the test. And why they don't trust the test? Because the test they're used to, which is the kind of laboratory test that is being done in the health center, is known to have tons of type 1, type 2 errors. That's such a great test, and they think, well, this test, it's a new one. How do I know? You know, it has low. And therefore, people don't really comply with it. We can continue. All that has the consequence that teaching health behavior is not easy. And although I showed you evidence of successful information campaign, the world is littered with ineffective information campaign. Many of them I've evaluated, so I'm very well-known, very familiar to them. So deworming is, people are very willing to take the pills, but as long as they are free, but educating them on not wearing shoes and all that doesn't change behavior. I was involved with Pascaline and Michael Kramer with evaluating the HIV/AIDS prevention program, or the government one, UNICEF, formed over many years, lots of formative research, so on and so forth. We find no impact of the actual program, in contrast with the very simple intervention of telling girls, the older men are more risky than the... but this program made no difference, and I can tell you why a little later if people are interested. Some public health campaigns are more effective, but then this one can sometimes also have negative unintended consequences. For example, in Bangladesh, they started putting skull and bones to prevent people to drink the water from arsenic-contaminated wells. So people shifted to shallow wells, which didn't have the skull and bone. But the shallow well, the water is so polluted that the kids got sick drinking that water. In fact, many more people died of drinking. That's the government campaign. It's not an RCT. It's an ex-post evaluation of a government campaign, showing that this was, in fact, counterproductive from the objective of child survival. Just to say that it's difficult to do information. Good. Another possibility is that there is a social equilibrium aspect. So people, for example, for immunization, understand that the benefits of immunization are mainly social. So they are effect for me, but it's good for everyone else. And they want to signal that they are the kind of parents who do good things for their child and for the community. And so if you help them signal that they are good parents, that would make them more willing to do it. So Anne Kering did a study in Sierra Leone where she offered people silicone bracelets for when the kids got immunized. And for each immunization, you got a bracelet of a different colors. And she did find impact of that. If you go down one. And a nice feature of the experiment, to know whether it's really social signaling that matters, is that she also introduced a treatment where everybody got a bracelet. And so here what we learned is that actually all the treatment is effective, so it's more about, again, the small incentive, et cetera, than the social signaling. So I think the jury is still out on whether that's important, but she's redoing more work to show that. There's more research to do. We can continue. With many of the above explanation, the information, the trust, the conveying the social norm, you might expect that social networks, I'm not talking about Facebook, I'm talking about the informal social network, the ties between people in community, are likely to play a key role. And that's not, clearly not, I'm not the first one to have this, to make this astute observation. So using the community has been done in many ways. So common ideas, and one that was, for example, that we saw again play out in the COVID vaccines is the idea of using influential people to convey a message. The first one is to go with, stars. Ben Olken, Abhijit Banerjee, and others have a paper where local stars sent messages on Twitter about immunization, and they found that the messages sent by the stars are like diffuse much more than the more official WHO-style message. During the COVID-19 crisis at the very beginning, Abhijit, who is sort of a star of his own in West Bengal, where he's from, and he was also the chair of the COVID response committee, so everybody knew him, send messages by video to people, encouraging them to socially distance and wear masks and protect each other and so on. And this had pretty large impact on people's behavior. So that's one way to go. Another way to go is the locally influential people. So that's the immunization corps that was part of the COVID-19 response here. And that's often invoked as something possible. So local leaders, etc. The problem is who is influential and who determines who is influential. So the network theory suggests that the people who are influential are people who are highly central in the network. What is a central person? Is someone who has many friends who themselves have many friends. So think about your Google ranking. It's like, are you connected to a lot of people who themselves are connected to a lot of people? So this is someone who is influential because if they have an opinion, they'll transmit it to their many friends, who in turn will transmit it to their many friends, and the information will circulate fast. The problem is, how do you know who these people are? I have a lot of research showing that shortcuts don't really work. So we say, oh, these are the religious leader, or the shopkeeper, or the school teachers. Well, it turns out, it's hard to put a tag on who is influential because it really depends in very, very fine way on this particular village. So in one village, it's going to be the shopkeeper. In another village, it's the religious leader. In another village, it's yet some other person that you've never heard of coming from the outside. So the outsiders, government, NGO, anybody, are not very good at tagging the influential people. So if you had an infinite amount of time, can you go one? What you could do is to try to figure out who is whose friend, map the entire social network, but you don't have a lot of time. This is costly, and who is going to do that? So why not just ask people in the village, hey, who are the movers and shakers in your community? So if you guys are in department, institution, probably I could go to you and say, who should I go talk to? So if I have a piece of news, I'm sure it circulates. Alternatively, you know who to not talk to when you don't want a particular news to make its way. So that's the ideas of gossips. So the idea of gossips is to ask a few people in a network who the influential people are. Now, you might feel, how could they possibly know? People have usually a very poor understanding of the social network. For I know who my friends are. I might have a vague idea of who my friends are, but certainly not beyond. And in principle, to know who is influential in a network, I should know all that, and people don't know all that. So how do we know they know? We can continue. So the reason why they might know is because although they might not know exactly who is friend with whom, they know who they've heard about. And if I've heard many times about someone from various people, then it is likely that this person is quite connected because everybody talks about them. So in this way, even though my knowledge of the network is not very precise, I might still be able to pinpoint who is the influential person. So that was our idea. So then we felt, well, now how about trying to ask people, in reality, would it work? And we did an intervention on immunization in we first did a small pilot about something inconsequential to see whether we can identify people. And then once it seemed that people did know in the village, we carried a large experiment in Haryana with the government of Haryana, trying out several things in isolation and together. One was replicating an incentive experiment, this time with self-food minutes. One was doing the very traditional thing of sending people SMS reminders. And the third one was this seed intervention, where we would basically nominate ambassadors for immunization in the village. We did that in Haryana in a very large scale. The seeds we tried, either this gossip, which is we went and asked villagers to nominate, hey, who is the mover and shaker in your community? Or in some villages, we asked them, who would you trust? Who do you think people in general trust about health in your community? Which is a different question. And the third one was, who is both a gossip and trusted? And then we selected 5 people who had been nominated through either of this process, according to the village. Plus, in some villages, we just selected random seed to compare. And we enrolled them as seed. We went to talk to them. So this is how we get the village. And who are the people who, when they share information, many people in the village get to know about it? For example, a music festival, a street fair, blah, blah, blah. Then we can... The trusted one as who are the people that you and many villagers trust within and outside this neighborhood. And then next is the trusted gossip that it's a bit of a mouthful. We can continue. Then we visited them. Then if they agreed to participate, we messaged them about once a month, and we gave them the message to tell people that the immunization is coming and it's important. And if they were incentive, we also told them to tell them there is an incentive. We can continue. The basic result, the most important part to see is that there are really only 2 interventions that are effective, the gossip intervention and providing incentive. And they are about equally effective, except that the gossip intervention is almost free and the incentive is very expensive. So the gossip intervention becomes more, cost effective. Moving forward, what we did is to all sorts of complicated statistical machinery that is not interesting per se, to determine which combination of treatment was the most effective. And perhaps it's not going to surprise you that it's to do everything together. To do, in terms of increasing the number of immunization, is to have gossips, incentive, and reminders. Turns out, perhaps to nobody's surprise, to be the most effective in terms of increasing the number of immunization. And then if we look at the most cost-effective program, which is where you increase the immunization the most per dollar, then because incentives are expensive, and in this setting, we already had 60% immunization, so a lot of people would get incentive that would have gotten immunized anyway. The most cost-effective is to do gossips and reminders together, because it's very, very, very cheap, and it increases immunization a lot. Next. I'll show you a last. No, it's fine. Let's not. I won't show you this one. I'll just tell you what it is. The last thing we did, and this is what I should have put a graph as opposed to a table, is to say, well, let's take the most effective program and see whether there are some villages where it's more effective than others. And so we developed statistical tools to be able to tell us where it's going to work the best and where it's not working as well. And what we're finding is that in places where it's working the best, which turns out to be the places where immunization rates are low to start with, the effects are very, very high, similarly high to the effect we had in Udaipur, about a tripling of immunization rates in those very, very low immunization villages. And therefore, again, we reproduce the result that in those villages, it is cost-effective to do the full package as opposed to do nothing. You get more immunization per dollar by adding all of this intervention than by continuing with the status quo. So let me finish with policy implications. The first one is that there are large benefits to make preventative action as easy as possible, because any little friction is you're going to lose a lot of people. In contrast, when overuse is an issue, for example, ACT, antibiotics, etc., The opposite makes it just a little bit harder. For example, that it's not available in every pharmacy with no test or no prescription or something like that, like it is in India today. In developing countries, at least the one I work with, things are almost the opposite of what it should be in this dimension, which is the preventing thing is hard and the curative things is easy, which is why life of a person who tries to stay healthy in a poor country is so much harder. You can continue. So my idea is that we therefore should go in the direction of providing things for free, making them cheap or completely free whenever possible, or even compensate people for the time they take to do the activity, which is basically a form of making it free. So this gives three questions among policymakers when we make this type of suggestion. The first one is, but maybe perhaps we'll misuse a good that they get for free. Maybe people will get used to handouts, and maybe people will be discouraged from buying the goods. So several years ago, this was the ruling ideology among the social marketers of good stuff, like bed nets, filters, and so on, that you cannot give things for free because the people will not use them the way it should be. Through JPAL, in particular, Pascaline Dupas started a bunch of studies to look at it. The question is like, do you know that, or do you suspect that? And she ran several projects. I'll show you one of them now, which is the experiment I already mentioned, where some people got bed nets for free, completely free, and some people got it at various subsidized prices. That in round one. And then what you can see, it's fine, you can stop here and then I'll tell you when to switch. The first thing you see is what we already showed you, which is if people receive a bed net and have to pay for it, they are less likely to get it. And even at about half the price, very few people get it. Next slide. What she did then is to monitor usage by sending people just after nightfall when the bed net should be up. And what you see is that this idea that people wouldn't use a net they got for free is just incorrect. That, in fact, the usage rate is completely uncorrelated with how much people have to pay. If they have one, they use it. Next. Then we come the result I showed you later, which is, do people get used to handouts or something like that? And in fact, it's the opposite, which is it's the people who got the free offer and therefore are most likely to have one, who are more likely to pay for one later. So they didn't get used to handouts; they got used to bed nets, which was in fact a good thing. Finally, another worry that people express is that, but this is going to destroy the market because people will not want to buy something that they could possibly get for free. And what she's looking at is whether the neighbors are more likely to get a bed net if many of their neighbors got it for free or less likely. And she finds that, in fact, the neighbors are more likely to get bed nets when there is a high concentration of free bed nets around them. Perhaps because they see many people use it and the knowledge diffuses. Then if most people had to pay, then half the people had to pay for it, so there is less around. So in conclusion, demand for health is fascinating. There is lots we don't understand, and we need to understand. And this is for the next chapter. It makes for a very complicated supply response because when we have this complicated motives and understanding and not very well regulated healthcare markets where everybody can kind of come on, it gives you this highly diverse healthcare provision landscapes that are both part of the solution and part of the problem sometimes. Thank you very much, and all the best to you. I don't know if I didn't pay too much attention to the time, so I don't know if there are questions that I should stay for, or we should continue with the program.
Thank you. So.
Diffusion of innovations, and I think I saw harmonics in your presentation from him. Has he influenced you?
Oh, I have, yes. So basically these basic models are kind of still very much in the type of things that are in the back of our minds when we think about how innovation diffuses. Absolutely.
Everyone can hear me. My name is Ellie Zambrano. I'm here with the Center for Innovation in Social Work and Health at Boston University. And I wanted to see if you could comment on the role of health confidence in low and middle income countries, specifically the patient engagement and the role that it plays in some of the work you've been talking about.
Health confidence. So I'm a bit concerned that it's potentially a piece of language that I don't fully understand the use of. So I'm going to try just from how I understand what it means, and I'm sure there is a literature of it on it that I ignore. One of the things that is that we also see. For example, I didn't talk at all about healthcare supply, but the people who are treating poor people in developing countries spend very little time on them. So, for example, in India, if you go to a health practitioners, the average time is 1 minute. The average number of questions is 2, and the average of medication you go back home with is 3. So that's the 1, 2, 3. And that doesn't foster an environment where people are confident to take either to advocate for their needs or to represent them and so on. And it also actually, strangely enough, doesn't foster an environment where the providers, many of whom are actually not qualified or don't have a diploma, don't have an MD, but are still providing medicine and prescribing antibiotics and giving shots and all that, they also don't have that much confidence in their own ability. And that translates into something that's the no-do gap, which is this providers who are not very well trained and don't know very much do even less. When you compare, for example, their behavior and their answers to standardized patient and vignettes to what they do if they see the same standardized patient or standardized patient with the same same disease, they do much, much, much less than when they know what to do. And in part, it's related to this, that they don't, the patients don't really trust them, and they don't trust the patient, and nobody trusts each other, so they don't want to do, and that is part also of the reason why there is so much antibiotic provision or steroid shots, etc., and when it's not needed, because it's what the patient expects, and if the patient don't trust the provider also don't trust themselves to tell them, look, all you need is this or that.
Give some comment on what you find mistakes that research has made, so some pitfalls that people in the room should watch out for when they lead research projects and they conduct research projects.
Oh, that's a long, long list. So, and I could feel a whole. In fact, Ben Olken has a wonderful presentation about all his failures. So I'm not gonna do all of them, but I'll give you a recent example, which is it's about the attitude that we have and the preconception that we bring to the field when we do research, and also why I think it's also important who does the research as a consequence. So that's my example of my work. So we, very early in the pandemic, at the same time as we started the project, I showed you about the video of Abhijit. We also were very keen to do something about addressing disparities in COVID prevention behavior in the US. And this was early in the pandemic. We were very concerned about the Hispanic and the Black community. And this was early, so there was no data yet telling us that how bad the disparity in outcomes were going to be. But we were concerned that most of the faces that spoke about COVID were white, and there was stories that we heard about masks, and in particular African-American males being harassed for wearing masks and so on. So we started this project with the idea that there might be it's important to address the problem statement for us was that, maybe for African-American communities in particular, it's going to be harder to understand what they can do to protect themselves against COVID the best possible. At the beginning, it was just mask and social distancing, economically, socially, understanding-wise, and so on. And therefore, we need to develop a research project on that. And we developed a great research project with the Center for Diversity and Inclusion at UGHE. And we worked with a lot of physicians. We had focus groups on what their understanding with their patients and so on. We developed first smaller study, not huge, not tiny, like 10,000 people study online to understand whether people responded to videos of doctors explaining to them about health and about COVID, and to see whether people were more responsive to a Black doctor versus a white doctor, whether that was different for white and Black people. And anyway, so we did all this. We found useful things in the process. One of them was that people were quite responsive to videos. So as a result of that, we launched a huge campaign just before Thanksgiving and Christmas 2020. If you remember, the motto was "Stay home." So we launched a big campaign where people, where we told, we basically people got ads on their phones. You might have gotten one because we sent 30 billion of them. And that worked, actually. People did stay home more when we randomized at the geography level, and we had a small reduction in COVID cases, which, considering it was a free thing to do, was good. So all that is the good part. But I'm coming to the pitfall now, which was the entire premise of this research was that Black communities were going to be less likely to protect themselves against COVID than white communities. And it's not true. It's just not true. It's completely wrong. When we went into the project, we collected data on that, and we realized actually Black people were more likely to wear masks, they were more likely to be socially distanced, they were more likely to get vaccinated when the vaccines became available, and so on and so forth. So this entire project started with the totally wrong premise about what the problem was. Now, it turns out we were lucky or open-ended enough that we developed something that was of use but with the wrong angle point and with a very patronizing angle point. So it was not a proud moment from this point of view. That's so that the example. So I guess the pitfall is to not even realize which is the color of the glasses you're wearing. And sometimes it can be costly. In our case, we ended up doing something that was useful, but it could not have been.
On immunization, but also on the expectations we have from how societies are going to react to this. As we think about my experience with digital technology, particularly using AI to make penetration into the healthcare system, and I'm not aware of a path forward for this, and I'm wondering if it is a parallel to immunization. Can we do something about digital technology, and what is the way forward?
So I think there is a lot we don't know about what's useful and what's useful in practice. So I have a small window of it working on e-health, so that's not artificial intelligence. That's like a very simple application that frontline workers have on their phone. So it seems like a total no-brainer. I'll give you two kind of warning things there. The first one is the one we developed for the immunization project. We just wanted a registry for immunizing the kids and then a way to update it. I thought it would be simple. Like, it wasn't. It took the group we were working with so long to develop this registry. I just couldn't understand. I thought they were really bad. But in fact, so after that, the government of Haryana decided to roll out a much better e-health platform, and they have that, and the nurses are supposed to have it, and we remain very involved in it because we were going to kind of plug in both the reminders and the gossip type intervention on this platform, and nobody uses it. The nurses find it impossible to navigate. There are too many options. It takes too much time. So that's not saying AI cannot be helpful, but it's saying so often we get very taken by the glossy, or we, and it's not just we, the researchers, and it can be the government partner and so on, and it's not as practical in the field. So my guess, completely uninformed, is that it's going to take some time before this is actually of practical use in the field, and you have to be pretty patient.
It was really an absolutely amazing lecture. Thank you once again. I'm sure we could have continued for many, many hours. Definitely you'll be on our list for a next guest speaker, and we are going to ask for 2 hours of your time. So thank you so much. We are really, really grateful. It was amazing, a lot to share with us, and we really appreciate your time. We need to move on because almost the time is running out, so we are going to continue with the panel, and I'm going to invite Professor Rifat Hatun with the panelists to approach a very interesting question. So I would like Professor Rifat Hatun to introduce himself and then the panelists, and maybe in the next 30-35 minutes for them to respond. Thank you.
Okay, thank you. Do we need a microphone? Yes, they're recording. Okay. Great. Well, that was a super tour de force, Esther. Thank you very much. Extremely informative. We could have asked 100 questions, but we'll leave that for another time. And this is a very hard act to follow, but I'm very happy to say that we have a stellar panel to follow a really excellent lecture. So I'm Rifat Hatun. I'm Professor of Global Health Systems at Harvard University. I work at the School of Public Health and also at the medical school. My interests are in health systems and innovation. So much of what Esther was saying was of great interest to me. But our topic is also very important. We're going to focus on what Andrew Weiss was talking about, suffering, and trying to understand, hopefully the panel will be able to address the issue of alleviation of suffering. What are the most cost-effective interventions? Of course, there are so many questions that come to mind. What is suffering? How do we recognize it? How do we measure it? What works, where, how, and under what conditions, as we heard today, and then what interventions have the most impact? I'm sure the panel will be able to shed some light to some of those questions. And on the panel we have first Dr. Joya Mukherjee, a close friend and a colleague, who's the Chief Medical Officer of Partners in Health. Joya has dedicated her life to alleviating suffering and poverty around the world. Then we have Seti Solomon, who's the commercial attaché at the Embassy of Rwanda, where Partners does a lot of work. Third, we have Claire Wagner, Dr. Claire Wagner, a fellow physician, who's head of corporate strategy at Bill & Melinda Gates Foundation Medical Research Institute. And finally, we have Michael Fairbanks, who's chairman of the board of Akagera Medicines. He's also an advisor to the president of Rwanda. So I'm going to start with Joya. And we have 30 minutes altogether, so about 5-minute intervention each, then we'll have 10 minutes of a conversation. So what is suffering and how do we alleviate it?
That's a big question, Rifat. You said you're going to go to me first. You didn't tell me it would be that.
Well, you're the best person to answer difficult questions.
So, first I want to thank everyone for this great event, and thanks especially to Andrew and Bonnie and the Weiss family, and for Christina. And that was a wonderful talk by Professor Duflo. I think suffering is something we see, and we know what it is. We see that impoverishment particularly is a particular form of suffering. Mothers can't feed their children. We hear, the cries of hungry, babies. We've seen people around the world in a lot of pain from, untreated medical problems. So in our department, I'm also a professor in the Department of Global Health and Social Medicine. We think about individual suffering, but we also think about social suffering, which is the suffering when the community itself does not have the means to be well. And that wellness can be physical, it can be mental, it can be, psychological. And so much of the work that we've done with our partners in Rwanda that Joe laid out so well, from starting with a very basic set of interventions to rebuild the system after the terrible genocide, which caused, of course, massive social suffering, and then focus on an individual through treatment, of tuberculosis or malaria, and over time, building systems that people can rely on is a way to address suffering. So I'll just relate one small story about sort of individual suffering and social suffering. When we first started working in Rwanda many years ago, 2005, there was a little girl who came in with a coma, and she was suffering. Her mother, who had lost 2 other children to malaria, was terrified and suffering. And we did not have beds in the hospital. We placed her on a mat. The hospital was dilapidated and falling down, but we did have tests and we had medicines. And we gave her some medicine. She didn't get better. She had such low blood count that we had to send her to another hospital to get blood. And our team said to the driver, please bring her back, because we want people in the community to feel the hope of this little girl's survival. And so the driver sat all night with the family as this little girl was getting blood, and she came back. And the next morning on rounds, she was sitting up and laughing and clapping her hands, and her mother was crying really tears of joy. But what was most impressive to me, or annoying at the time, because we were all very tired from being up all night, on rounds there was a crush of teenage girls at the door. And I said to a nurse who's still with us, who's still teaching at UGHE, I said, Peter, get those girls out of here. What are they doing? It's a hospital. And he went and kind of scolded them. And then he came back to me sheepishly and said, they came to see the little girl who lived. So when you think of suffering, these are families that suffered a genocide, a country that's suffering from disrepair and dilapidation, individual child and mother that are suffering, and that doing what we need to do to treat the child, to give dignity to the family, elevates the status of the entire community. And I think when we think about University of Global Health Equity and the Research Institute, it is really to alleviate social suffering, like Jim Kim said, at scale. at scale. We've been able to scale those interventions with the amazing government of Rwanda to teach people how to care in that way. And I think there's technical interventions, and then there are these much more broad-based social interventions. Both are critical. You can have the pill to alleviate suffering from malaria, but if you don't have the context, understand it, you can't do it. So I think the interdisciplinary work we do, that is biologic focus, that is focused on economics, that is focused on social science, that is focused on population health, that's really how we get to the issue of social suffering, but person by person.
Yeah, that's a really wonderful introduction, and you've set a very broad canvas, individual and social suffering, which has implications in terms of how we think in relation to the interventions, individual level interventions that might be cost effective, but also systems level interventions that might be cost effective. Obviously, as a systems person, I would strongly support interventions at scale. But let me move to Michael. I know that Michael has been doing quite a lot of work around tuberculosis.
Yeah.
And if he could share his views regarding suffering in relation to TB and what we can do to alleviate and what might be cost effective.
Yeah, thank you very much. So every country, including Rwanda, every city, including Boston, has 7 forms of capital. I'm going to go through them really fast. The first one is just basic factors like subsoil assets and sunshine and location. The second is man-made capital like buildings and roads and satellite dishes. The third is just money, the velocity of money, the supply of money, the exchange rate of money. The top 4 forms of capital are harder to see and harder to measure, and sometimes we don't think about manipulating them. The first one would be institutional capital, norms and attitudes inside buildings like this. Knowledge capital, like archives of information, intellectual property. The next one up would be human capital, which is just knowledge capital with legs. It can get on an airplane and go away. It can come to schools like this and get better. It's skills and abilities. And then finally, there's cultural capital, which is the most interesting, the hardest to see, the thing we never think about because fish don't understand the water in which they swim. We don't understand cultural capital either. But it's belief in competition, optimism about the future, tolerance for new ideas. It's all that kind of stuff. Tuberculosis thrives in an environment that's based on the lowest forms of capital. So what happens is poverty is correlated with TB and vice versa. The causality runs in both directions. So when you have an economy based on basic factors, the only competition you're in is to see which country can stay the poorest the longest until its society disintegrates. Because when you take a subsoil asset out of the ground, push it down a road, and sell it out in the world, the only cost you can manage is the cost of labor. So you push labor costs down, wages down, in order to be competitive. That creates the conditions for TB, because TB thrives in poverty. Now, poverty is not just what I just said, it's also the loss of aspirations and hope. It means that your dignity goes down, not because someone told you you're less, but you just feel that way because you can't have shelter, nutrition, medical care, and education for your children, and you feel bad about it. So what can we do to eradicate poverty? What are the 5 things we can do? Well, it's about restoring and improving the higher forms of capital. Let's talk about culture for a second. Paul Farmer had it right, and I brought this up because I just want to get the quote right. The Gates Foundation has it right. Claire has it right. The Gates has it right because Claire is there. So what happens is, and Paul Kagame has it right, when Paul said, the essence of global health equity is the idea that something so precious as health might be viewed as a right. Paul, Joya, everybody over there is famous for influencing policymakers around the world by saying that every single person deserves the same health care. This has been their jihad. This is what's been hard about PIH. You're laughing because I'm underselling it, aren't I? This has been their jihad. You know, when I asked Agnes Binagwaho once, why are you working so hard to make sure everybody has the same health care as your daughters, she turned it around on me the way only an African can and said, why would I want to live in a country where kids don't have the same health care as my kids? That's part of the ethos of Rwanda. It's certainly, I don't know if PIH influenced them or they influenced PIH, or indeed the causality, it goes both ways in this regard as well. Let's talk about institutional capital. In order to eradicate TB, we've got to make sure that the institutions are represented by Black people on the planet Earth. The Prime Minister of Barbados just said at the UN General Assembly last month that there's 1.5 million Black people in the world and they don't have representation on the Security Council. And when the Security Council has a veto, that means they can veto anything that's bad for them but good for everyone else. That's institutional capital. This is one of the reasons TB is not being solved. Let's look at knowledge capital. The science of TB is a 75-year-old science, and you'll correct me if I'm wrong, 75-year-old paradigm where they tried to poison the mycobacterium before they killed the patient. That's the wrong paradigm. The right paradigm is to take insights from other domains of science, like oncology, and apply those paradigms to infectious diseases so that you can have low drug-drug interaction, low toxicity, bound the problem where there's no toxicity. These results happen. Dr. Daryl Drummond back there in the corner is my partner at Akagera Medicines, or as President Kagame says it so much more poetically. We all say Akagera, don't we? President Kagame calls it Akajara, which I just love. But inventing a new paradigm for what's happening. And then finally, what the Weisses are doing is they're building a cluster of related and supporting industries in Rwanda. Rwanda right now has the African Medical Association coming there, and they defeated Egypt and Kenya and Nigeria to get that. The African Development Bank just put in place their Biotech Institute in Rwanda. BioNTech is bringing 100 scientists from Europe and around the world to live in Rwanda. And the Weiss Institute just turbocharged the UGHE by bringing in knowledge capital, archives of information, different types of biobanks with tissues. They're turbocharging the knowledge capital of Rwanda. By building these higher forms of capital, we're going to make Rwanda the center of medical technology in all of Africa. And God bless those of you from Cape Town who want to fight me on this. Or Kenya. That doesn't bother me at all. So what's going to happen is, the Weiss Institute is investing in the higher forms of capital, which is the way you build an economy in Africa, and it's the way you finally defeat tuberculosis.
Great, thank you. Thank you, Michael. This was very interesting. So these cost-effective interventions can be focused on various forms of capital, which of course are difficult to measure, as I'm sure economists in the room will tell us. But let's move to Claire. Claire, you got it right. So could you tell us what you're doing?
Thank you for that. I want to also thank Christina and Andrew and Bonnie Weiss for this amazing opportunity to be part of this launch, and what an incredible effort. So thank you all. And I think I'll try and strike down the middle of where Joya and Mike have already commented on and speak to a few different cost-effective interventions. I say cost-effective with quotes around it because I know Paul and Joya maybe can back me up on this, would often take umbrage with that word. But I think actually one of the most cost-effective interventions, if I can use that word, is not having a failure of imagination. And that's what Jim was just saying earlier, and what Paul always said, is to not have a failure of imagination when it comes to public health interventions. And I remember also when I had the opportunity to work for Dr. Agnes Benaguajo and Dr. Paul Farmer for 3 years in Rwanda as a research assistant, which was the opportunity of a lifetime, I also was supported to go shadow in the Central Public Referral Hospital called CHUK, which many of you I'm sure know well. And I remember I was shadowing. I had no real contribution to make at the time, and observed early on, this was over a decade ago, so many pediatric patients who were dying of cancer, totally treatable cancers. And I remember one patient in particular who I followed for weeks as his disease progressed, and as the physicians pooled their personal funds to purchase through private mechanisms in Europe chemotherapy drugs that were indicated for the disease that they thought he had, although there was no appropriate diagnostic capacity at the time. Fast forward 3, 5, 7 years, and for those of you who are involved in the Global Cancer Program at Butaro and in the country in general, I know Chris and Scott and others are here, it is a perfect example of the ways in which partners have come together, including partners in health, the government of Rwanda, and so many others to advance advance the country and really the world towards seeing cancer as a treatable and often preventable illness. And I think I bring that up because it is the ethos in this room right now, this seeing the impossible not as impossible, but more of a question. So I did want to start with that. I think secondly, and I'll just maybe give one example in the interest of time, is, I'll draw also on a lesson from Rwanda here, that one of the most cost-effective interventions, I think, was and is the focus on the most vulnerable. And so really equity as your strategy, and that you put that first and foremost every time. And the example that I was most familiar with during the years that I was there was the rollout of the HPV vaccine. And the question was, okay, we have this 2.5 million doses from Merck in a great public-private partnership. How are we going to reach the most girls at the time? And the question wasn't, oh, well, let's put it in the most populated places. It was, where are the girls? And the girls are in school. So let's bring the vaccine to the schools. And for those girls who aren't in school, let's go to the refugee camps. And you bake that into your initial strategy. So I think that is also one of the most cost-effective ways you can prevent suffering. And just an example from the Gates world. So for those of you who aren't as familiar, we are a small subsidiary here in Kendall Square. We're a nonprofit pharmaceutical development organization. We have about a dozen assets in development right now across tuberculosis, malaria, MNCH, and diarrheal diseases. And we actually are doing the clinical studies all over the world right now. One example I'll give is in also the tuberculosis space. As Mike was saying, this is one of the. It's so easy to forget that TB is the top infectious disease killer in the world, because we look, right here in Boston, it's not. But for most of the world, there is immense suffering, and preventable and treatable suffering in many cases. And so, for example, one of the ways that at the Gates Medical Research Institute we see our ability to contribute is at the intersection of big global health problems and limited commercial incentives. And we are fortunate to be financed in a generous way by the Gates Foundation to actually run these studies. And to one program in particular that we're excited about is our M72 program, which is another example of a public-private partnership. We've in-licensed an asset from GSK to develop a vaccine that in phase 2B studies showed a 50 to 70% reduction in conversion from latent to active TB. And if this works, it could have an enormous impact, not just clinically, but epidemiologically. So I think that is product development, like Mike is doing, and so many others in this room, I'm sure, are doing. Product development and product introduction in a smart and focused way can also have a huge impact in this space. Thank you.
Great, thank you, Claire, for these really excellent contributions. In particular, getting us to think about not having failure of imagination. I think there's no shortage of this at PIH. I'm sure there'll be no shortage of that at the new institute. But what you said very importantly was equity. We often think of cost effectiveness that focuses on notions of efficiency. That provides value for money, but actually what's important is also to ensure we have value for many, for those all who need it. So let's rethink the boundaries of the most effective interventions in terms of who they're targeting. But you also said that we need to create an ecosystem for sort of innovation, and I can't think of a better person to tell us what's happening in Rwanda. So Tessie, over to you.
Thank you. I think the fact that we're all gathered here is a testament of the fact that our government is very keen in a healthy economy, which is underpinned by a healthy population, which in turn is maintained by a well-resourced and sustainable health system. Rwanda's investment in health sector is currently above the Abuja Declaration threshold, which is 15%, and will continue to increase with the country's economic growth. And if I may brag a little bit about something non-health related aspects of Rwanda, we're the second fastest growing economy in Africa. We have a very young population and still growing. One of the fifth safest countries to walk in the evenings. The lowest debt to ratio in the region with a very stable currency. We're the second best doing business in Africa and 29th globally. The first for government transparency in Africa, and I'm sure most of you know that most women in parliament and a very gender-balanced cabinet in the world. Going back to the innovation part of it, technology and innovation has been at the heart of our transformation journey in Rwanda. Rwanda Innovation Fund had opened last year with an aim to support the formation of a mature, innovative ecosystem and investing not only in our country but other African companies, bringing to market innovative solutions addressing the challenges of our continent as a whole. We have a strong focus on sustainable development in infra-tech sectors, including health tech, agri-tech, ed-tech, smart cities, and clean technologies. We've also built the Center for the Fourth Industrial Revolution, and its vision is centered around the trajectory of Rwanda's digital transformation through progressive technology governance that's agile and human-centered. I can also add one more. We have a Kigali Innovative City, which is at the core of Rwanda's vision to become a Pan-African hub for tech and innovation. The building supports connective ecosystem with a concentration of game-changing startups, innovative companies, financial institutions, academia, etc. And last but not least, I would say that we also have homegrown solutions. We have a car-free day that is pretty famous, I think, with a lot of people, that we do physical exercise twice a month. And we are also using one of our greatest resources, which is ourselves, to prevent any future diseases. Thank you.
Yeah. Thank you, Seti. Well, Kenya and South Africa have a lot to worry about, it seems, from Rwanda.
Yes, they do.
So I'm going to give a heads up to my panelists, because I'm going to ask you to the sort of last 30-second intervention to tell the audience what you think the most cost-effective intervention might be, or effective intervention, not just cost-effective, but also equitable. But while you're thinking, I'm going to try and sum up what you've said, which I think provides a really wonderful backdrop to the Institute. I mean, you've said, all of you, while you're thinking, effectiveness is not just about interventions. So there are interventions at individual level, but also for conditions. But we also need to ensure that we're targeting vulnerable groups. This notion of equity is critically important. We need to build health systems to ensure we're alleviating not just individual suffering, but also social or societal suffering. But for all of this to happen, we need an enabling ecosystem for innovation with a healthy dose of imagination. So I think that's a very good sort of background to Institute's work. So you've had almost 30 seconds to think. So I know I'm asking you the impossible. So what would you invest in as a most effective intervention to alleviate suffering? Who would like to go first? Brave, Michael.
It's just a total coincidence that I'm saying this. It's not that the Weisses are over there and they're friends. It's clinical trials in Rwanda. Because what's going to happen is quite apart from just helping some people with a global standard of care when you do a trial, quite apart from building the fundamental infrastructure, the knowledge, the institutions, the cultural attitudes to do this, the multiplier effect on the economy is unbelievable. Because you have to recruit world-class nurses, doctors, and PhDs from the Rwandan diaspora to come home and get world-class salaries, and then they're going to spend money on beautiful homes and cars and people to work with them. A phase 1 trial is a really good business structure. There's high demand, low rivalry, and people make money, and hospitals and governments get paid a lot. In oncology, sometimes up to $100,000 a patient. It's a great business model and would have wide implications across the economy.
Interesting. Coming to this panel, I had not thought of this as being one of the interventions, but this has been really illuminating. Thank you. Who'd like to go next? Seti.
I can. I think I said it earlier, and I would say it again. I would invest highly on us, on people, and specifically on the youth, which is 70% are less than 35 years old. So I think the greatest assets is investment on people. That's what I would say. On youth, specifically.
On youth, okay. And we can count ourselves as part of the youth, yes?
Absolutely.
Good. It's a very, very wide confidence intervals nowadays. Good, excellent. So I'm going to go to Claire next, because I asked Joya to go first.
Yes, I think I'm going to get in trouble if I talk about what everyone should invest in, so I'm just going to not, and instead say that I think one of the biggest learnings that I learned from the Ministry of Health of Rwanda and from subsequent work and training myself is don't leave money on the table. And whether money is money or money is resources, whatnot, I think one of the biggest lessons, one of my takeaways from that time was there's always opportunities to create more value, and it doesn't have to be a zero-sum thing. I think one of the great examples that Joe brought up earlier was the HRH program in Rwanda, where the U.S. government invested directly in a bilateral fashion in Rwanda with HIV money to build the health human resources infrastructure. So always look for opportunities to create value, and that's where I would put my money.
Yes, value for money, but also value for many, yes? Equity is important. So, Joya.
Yeah, so I'll end with equity and just say that I think we need to interrogate what has been our long-held notion of cost effectiveness. What is cost? We know in the HIV era that the cost of drugs was $10,000 per patient per year. Now it's less than 60. What is effectiveness? We've been using regimens for acute leukemia that were substandard because we thought that was the only doable thing, and now we've pushed on to cure many more children. So I think with partnerships like the Weisses and Bill Cummings, of course, and Bill and Joyce, this magnificent infrastructure, it's partnerships that are going to give us equity. There's no one intervention, there's no cost, there's no effectiveness alone that can do it without the infrastructure, the platform, the partnerships. So I think it's on us to interrogate what kind of world we want to live in, what kind of world we want our children and grandchildren to inherit, and invest in that together.
Well, I can see that the new institute is going to have a really vibrant research agenda and really push the frontiers in relation to interventions aimed at alleviating suffering. And the panel has given us a flavor of what's to come. So I'd like to thank my panelists, first of all, for their excellent contributions, and secondly, for keeping to time. Thank you.
Thank you so much to Rifat and to all the panelists. I really think it was an excellent, excellent panel discussion. Thank you. We are continuing with our program, and on our program we were supposed to have Professor Agnes, the Vice Chancellor of our university, and I know it's going to be a big disappointment to everyone that she is not able to join online, and due to heavy rains in Kigali at the moment. So she has no internet, no connectivity. So she's very sorry about it. It's not really much that we can do. Already she wanted to be with us, but it's something like 11 p.m. at night in Kigali. So it's no way that she could go and find any electricity and internet. But definitely the message is that she is with us. I think she's one of the greatest supporters of this initiative and of the Institute. Someone who inspires not only me, but so many of us. So please take the message that she is with us, even if she can really not connect. And she is wishing all of us well, and definitely she will continue to support the Institute and the research, as she really is a big supporter and a big researcher in Rwanda. So this being said, we have one last video to show, and this is a message of support from the Minister of Health. So if you can play it.
Excellencies, Chancellor of UGHE, Dr. Kim Jim, Director of the Institute of Global Health Equity Research, Professor Christina Stefan, distinguished guests, members of academic and research institutions, ladies and gentlemen, good afternoon. It is a great honor to address you today on behalf of His Excellency, the President of the Republic of Rwanda and the people of Rwanda as we launch the Institute of Global Health Equity Research. It is a joy for us to see the University of Global Health Equity growing stronger with new institutes and academic programs that will undoubtedly yield positive impact to our country, the continent, and the globe. The Ministry of Health has a strong partnership with UGHE, and you can count on us for any support through the development and the expansion journey. The number of health research conducted on our continent is far below what should be our contribution to the scientific research and discovery arena, thus a testament to the timeliness of this initiative. The Ministry is aligned to the Institute of Global Health Equity Research's vision of training the next generation of top-class researchers in Africa and producing the most impactful and innovative research. We are looking forward to a close collaboration with the research centers at the Rwanda Biomedical Center and the University of Rwanda as we build a strong research ecosystem in the country. There is no doubt that this institute will contribute to generating data and strong evidence that will inform policy, advocacy, and development in Rwanda, Africa, and beyond, with a special focus on those most in need. A warm congratulations to Professor Christina Stefan and the entire UGHE and PH team for taking this noble task to train researchers of the future. We pledge our full support to UGHE and the Institute of Global Health Equity Research in particular. Rwanda is happy to be associated to the establishment of the Institute and University of the Global Health Equity. You can count on us as one partners in health family. I thank you very much for your kind attention.
we are almost at the end of our program. And I would start by saying that not thinking it's possible, it's a failure of imagination. So this is not something that characterizes us, for sure. And as we are at the end of the, I would say, short program, despite the fact that it lasted for almost 3 hours, I truly hope that you have enjoyed this launch just as much as we did. And instead of a vote of thanks, as definitely I could lose myself thanking each and everyone who is behind the success of today, because there are so many people, I would rather end with a call to action, call for joining us, call for collaborating, funding, partnering for a more powerful and innovative research and training in Africa, and not only, and also beyond Africa. Make the impossible possible. Imagine a world where equitable healthcare, where equity is not just another word, but transforms into reality. We have great challenges, but also great opportunities. And with your help, with once was just imagination, will transform into reality. And I would end with a quote of Nelson Mandela again: it always seems impossible until it is done. And I have just one special person that I would really like to thank, and who really supported me and was behind me all the way, and this is Bonnie. She's just been really not a supporter. I mean, we hear a lot about Andrew, but also Bonnie. She became really a friend, for the last few months. And I would like to call both of them here, because it's due to them that we have the Institute. And I thank also Bill Cummings with us, who is really a great friend of Andrew and Bonnie. But Andrew and Bonnie made really the impossible possible, and we will see even more coming. So thank you from the bottom of my heart, not only from myself, but the Institute, Africa, and the world, and great things are still going to happen. Thank you to you all.